Right, okay. So, good evening. Today, welcome to the 7th session of this teaching. And today we are going to discuss polycystic ovaries. Right, let me just mute everyone. Right, that's better. Right, so today we are going to discuss polycystic ovarian syndrome or PCOS, right? So now, children, it's a very, very, very common topic, and it is one of the commonest topics that will come for your exams. And one of the commonest things you will find as clinical cases. So therefore, you need to be able to properly assess, diagnose, speak about exactly what is required, and to understand how to approach this problem. Okay, right. So now, if you look at all the cases that we get, mainly, right, there'll be only a few ways in which the women with polycystic ovarian syndrome or problems with polycystic ovaries syndrome will come to you. The first kind of woman mainly is the woman who will come to us with problems of menstrual irregularity. They are having problems with menstruation, right? So these kind of women and these women will have two subtypes. One of these, there are women who are coming with problems with infertility, or problems or women who are not worried about it. They have no fertility issues, but they have other issues, right, which they want to address and sort out. So the two main categories of women who are going to come to you are PCOS coupled with infertility and PCOS and PCOS without infertility. Is that clear? Right? So each of these types of women will require a different way of tackling them, right? So therefore, the first thing that comes into your mind, if a woman comes to you, they are going to come and tell you, okay, look, I have PCOS, please treat me, right? They will come to you with some sort of problems, which in your mind, you will make the diagnosis of PCOS, right? So what are these problems? What are these women? They can come with one problem, two, or several things together. One of the main things they will come to you with is with what? Menstrual irregularity. Okay, they will come to you and tell you, doctor, I have, I get a period now, and then I get another period in another 30-40 days, maybe 3 months, 4 months, right? Or I have not got a period for a long, long time, 6 months, 8 months, 10 months, right? So that is one form of menstrual irregularity they will come to you with. The second problem they will come to you with is connected to the first. They will tell you, look, doctor, I have periods which between periods or between bleeds, it takes 30, sometimes 40, 50, 60 days or more, right? And then suddenly I start to bleed, and I bleed for a long time. So a period of amenorrhea is followed by prolonged bleeding. Is also one way which women will come to us. Okay. Then there'll be another set of women who will come to you with this plus what? Cosmetic problems. They will tell you, my hair is falling off, right? It's not like a male, right? But this is a different kind of alopecia, right? Then they will tell you, I have increased growth of hair everywhere. What is that called, children? That's called hirsutism. Okay. And then they will also tell you, I have a lot of acne. Right. So these are problems that women will come to it. So acne, alopecia, hirsutism, right? And oily skin. What are these all together? Taken in all together are the features of what we call hyperandrogenism. Correct? So women might come to you with fertility issues and also features of hyperandrogenism. Right? So these are the main characteristics or main problems that the women will have. In your mind, then comes the diagnosis, is this polycystic ovaries. Remember, in the Rotterdam criteria, which we think about the diagnosis, now only 2 of these is more than enough without doing an ultrasound scan to confirm polycystic ovaries, right? For us to arrive at a diagnosis of a polycystic ovarian syndrome or disease. Is that clear? Right? So if we have menstrual irregularities coupled with features of hyperandrogenism, then it is enough for us to arrive at a diagnosis. At the same time, remember, hyperandrogenism may not be connected to clinical features of hypoandrogenemia, right? Because I was talking to you about what? Clinical features, apparent features of hyperandrogenism. What are these? Acne, oily skin, alopecia, and hirsutism. There will be women without any of these. Okay? Right? And they have menstrual irregularities, but there is no clinical hypoandrogenism. Okay? So what is the other thing that comes into play then? Whether she has biochemical hyperandrogenism. Do you understand? Right? So for us to arrive at a diagnosis of polycystic ovarian syndrome, even without doing a scan, right, we will need to prove 2 things. Number 1 is whether there is a menstrual irregularity. If it is coupled with features of clinical hyperandrogenism, yes, so we already have a diagnosis. However, if there are no features of clinical hyperandrogenism, we will need to look for what, children? Features of biochemical hypoandrogenism, right? For that, we have to do blood tests, what we will discuss shortly, right? In addition to that, then comes the ovarian morphology, or how the ovaries look like, right? So that is the third feature of a diagnosis of polycystic ovarian syndrome. Okay, so a morphology which shows polycystic ovaries, right, connected with features of hyperandrogenism, whether clinical or biochemical, will also consist of a diagnosis of polycystic ovarian syndrome. Okay, or features of either clinical or biochemical hyperandrogenism, right, coupled with menstrual irregularity, will also consist of a diagnosis of polycystic ovarian syndrome. Do you all understand? Right? So this is how we are going to look at this. So let's take the first thing for us to do is to think of a diagnosis. Now remember, for the management of patients, we have simply 2 or 3 things to address, right? That is why it is sort of simple. Number 1 problems that we have to address are menstrual irregularity, right? Got it? So some women will come to you with only problems with menstrual, and what they say is, okay, look, doctor, I don't like this. Can you please make sure that I get a period regularly, because I am very uncomfortable with not having a period. So then you have to treat the menstrual irregularity. There are some patients who will come to you with features of hyperandrogenism, but most of them will definitely be isolated hyperandrogenism or clinical features will not come to us. They will probably go to the dermatologist, right? They will to treat the acne. They will go to dietitians to get if they are very obese or the BMI is high, right? They will usually go to maybe an endocrinologist if their hair is falling off, or a dermatologist, that is alopecia, right? So they hardly ever make their way to us for these specific problems that is more connected with their cosmetic or their appearance, okay? And then, of course, the third feature, we diagnose by an ultrasound scan. Clear? Right. First of all, let's look at the criteria as to who we should think or what, how do we diagnose menstrual problems, right? So the usual feature is not frequent periods. The usual period, there is the gap between periods are more prolonged, okay? And why does that happen? Because remember, a cycle or a ovarian cycle is you have ovulation, right? Or say after menstruation, then slowly the estrogen and the estrogen rises. So there's a proliferative phase, then there's ovulation, and there's a secretory phase, and then the amount of progesterones quickly come down because the corpus luteal cells die, and therefore then there's nothing to sustain that secretory phase endometrium, and then it goes out. So it's a cycle. So why does that not happen in polycystic ovarian syndrome? Simply because there is no ovulation or there's anovulation, right? If she gets an ovulation once in 6 months, the woman will have a period once in 6 months, okay? She doesn't have an ovulation at all, the woman will get, she will have amenorrhea, right? Do you understand? So mostly it is a prolonged period of amenorrhea and then maybe followed by prolonged bleeding. How does the prolonged bleeding occur? It's this. Because we have only estrogens in the body, because a lot of follicles are producing estrogen only, they will thicken it, and there won't be any progesterone because there's no ovulation, okay? And it thickens so much that the upper layers of the thickened endometrium derives its blood supply from below, from the uterus, yeah? So the further it goes up, the higher levels of that thickened endometrium becomes ischemic and they start to break off. So when they start to break off, they will break off bit by bit. So that is why they have a bit of bleeding on, then again, and that goes on for a long time until it comes down again to a level where there is enough blood supply, and then it stops. And then again for a long time there is no bleeding. You understand? So that is how polycystic ovarian syndrome will have prolonged amenorrhea followed by irregular prolonged bleeding. Right? Got it? Do you understand the mechanism? So now, what are the definitions? The first definition you need to understand is we do not make a diagnosis of irregularity in the menstruation until the woman is at least 8 years post-menarche. Right? Say if a woman or a girl has a menarche at 12 years, okay, the rest of the period for about 8 years, right, that is after menarche, say from 11 years if she had it, until 19 years of age, it is considered that because the ovaries are just starting to work out, right, or start to put their eggs out, that there will be multicystic ovaries are common. Lot of follicles are common. It's just starting to react to the FSH and the LH. Do you understand? So by just looking at a 14-year-old girl and then putting the probe and this looks like polycystic ovarian syndrome, you should not make that diagnosis. Is that clear? So the definition is, children, from menarche, you have to go for more than 8 years and then only come to a diagnosis or write down the diagnosis. This is polycystic ovarian syndrome, right? Till then, yes, you can suspect if there is a sudden, if there is obese, if there are features of hyperandrogenism, yes, you can suspect and initiate methods over. But remember, most of the time, that even only after 8 years that we can make a proper definitive diagnosis about menstrual irregularities in a young girl. Is that clear? So how do you look at it? If we are looking at a girl who is just 1 year post menarche, from menarche to 1 year, okay? Gaps between bleeds up to 90 days are normal. She can have a bleed, okay? Then she can wait for 3 months and then have another bleed or a period, okay? You understand? After menarche. Then maybe another 2 months, then 3 months. So parents suddenly get worried. Okay, my daughter had a menarche first period, now no bleeding, right? So remember the gaps between, or she had the first 2 nicely and now doctor no bleeding, right? But that's normal. Do you understand? So you don't diagnose any problems with that. From 1 year to 3 years post menarche, okay, gaps, the normalcy is between 21 and 45 days. So even if there's a gap of 45 days, still it's considered normal. Do you understand? Then from 3 years up to perimenopausal age, the 3 years post menarche to perimenopausal age, maybe 40s, 45, 46 or more, the gap or the normalcy would mean a period between bleeds to be between 21 and 35 days. Is that clear? Do you understand? So anything longer than that is a menstrual irregularity. But remember, do not rush to make a diagnosis of menstrual irregularity in girls who is within 8 years after menarche. Is that clear? Leave it. Don't intervene. Okay? So that is what you have to understand, unless there's a clear indication to intervene. Is that clear, children? So that is what is called by a menstrual irregularity. Now, will you be able to diagnose that properly? Yes. Next, let's switch on to what we call features of hyperandrogenism. Okay. So in your brains, how is it divided? Into 2 features, right? We have clinical features of hyperandrogenism, okay, and then we have biochemical features of hyperandrogenism. Is that clear? Right. So first, let us look at the clinical features of hyperandrogenism. What are these? Right? Number 1 is what? We have acne. So acne, children, is something that we cannot, yes, there is acne all over the face, but we cannot gauge it. We cannot say how severe it is. For the moment, there are no internationally or nationally acclaimed or checked ways of gauging acne. So you see it's there. Okay, but do you understand? So you can say it is different kinds, but there is no way to assess it. But if there is acne, then you say there is acne. That is number 1. The second clinical feature which you have to assess is what? Hirsutism. Right? What is hirsutism? Hirsutism is the increased growth of terminal hair. And what is terminal hair? There are 2 kinds of hair, right? One is vellus and the other is terminal. What is the difference? Vellus hair you find everywhere. It's thin, not very pigmented, right? And it is not found in 3 places only. What are these 3 places, children? In the body. The lips, the soles down there, and the palms. Anit hamatanama vellus hair. Okay. Terminal hair is most commonly found where? Eyebrows, underarms, pubic hair, right? All these places you can see the terminal hair. So terminal hair, So the change of terminal hair or vellus hair into terminal hair in places that they should not be is a feature of hirsutism. Okay, do you understand? Right. Basically, women do not want hair to be where they are. But remember, there are huge ethnic variation. So in some ethnicities, there'll be more vellus hair that looks like terminal hair. Okay, so they may be darker. There may be the genes might give us more hair. So hirsutism is a very, very subjective sort of understanding in the world. In some parts of the world, it might not be called hirsutism. Do you understand? In some part of the world, if the whole population has more fine vellus hair and less terminal hair, right? And if a woman has hair, terminal hair elsewhere, and it looks like, then it will be called hirsutism. The same woman with a different skin in a different region may not be called having hirsutism. Okay, so there are different ways in which beauty, hirsutism, body hair is taken in different ethnicities. So if you want to judge it, it's very difficult to get a universal sort of way of finding whether the woman has hirsutism, because it is varies with population to population, ethnicity, country, skin tone, color. Do you understand? White, black, brown, whatever it is. Do you understand? So therefore, one of the ways in which it is gauged is called what? The Ferriman-Galway score. Right? Have you heard of it? Ferriman, Gollway, Ferriman-Galway score. And it is now used as a modified Ferriman-Galway score, right? So there are certain characteristics there, right? So they, on the face, on the upper lip, lower lip, breast, back, lower arm, upper arm, pubic, buttocks, thigh. So you mark, and then finally you get a score. Depending on the score, then you say, okay, this woman has hirsutism or not, right? And that is also used if treatment is started to find how the effectiveness of treatment is, because you do the score now in the same woman and you do the score maybe 1 year later. Do you understand? So that is how hirsutism is assessed. But remember, it is extremely subjective depending on the country where the woman lives in. Is that clear? The third clinical thing is what? Alopecia. Okay. So what is alopecia? Is thinning and falling off of hair. Okay. Right. Give me one moment. Yeah. Yeah. Okay. Right. Okay. Sorry. My children. Right. Now, where were we? Right.
Alopecia.
Alopecia. So now alopecia is the thinning of hair, and thinning of hair is found in a woman in the midline, right? So the initial thinning is in the midline and it spreads like this, right? So that is what is called alopecia. And what is the score that is used? Ludwig, Ludwig score. Okay. So there's a Ludwig scale. You just Google that. You will see there are, I think, three of, you can divide it into different ones, and they are all drawn pictures, and you just tick off one of those, right? So it's a Ludwig scale, right? So that is how we are done. So it's mainly in the midline. It sort of first thins off, but the woman can cover it with all the hairstyles and everything. The second thing is slowly starts to go difficult sometimes, you know. Then the third, of course, is very difficult to cover. So you might need wigs and all. Do you understand? So it's called the Ludwig score or the Ludwig system of assessing alopecia. So these are the three important things that you need to think about, right? Is that clear? Next is, now that's done. So what have we done? We have done clinical features of hyperandrogenism, right? Next is we have to come to what? We have to come to biochemical features of hyperandrogenism, right? So to measure the, remember children, even if there is problems with menstruation, even if there are no clinical features of hyperandrogenism, there may be biochemical hyperandrogenism, which will consist the diagnosis of a polycystic ovarian syndrome. Clear? Right. To measure the biochemical features, we just basically do two things. What are these? Free testosterone and free androgen index. Okay? Days that we measured LH, all these are gone. We don't use that now because LH is highly variable because it comes in peaks and troughs, right? So therefore we don't use that now. So the two things is free testosterone and free androgen index. What do these testify? Now, if you look at the testosterone in the body, now these polycystic ovaries, it is thought that they produce more testosterone. That is why it gives features of hypoandrogenism. Okay. So what does free testosterone mean? Most of the androgens in the body, right, testosterone is bound by what? Very tightly bound by sex hormone binding globulin, SHGB, right? It's tightly bound. So therefore, this testosterone in women, most of it is bound. So therefore, it cannot exert its effects on the peripheral tissues like hair, acne, and all that. Is that clear? And also, it cannot have an effect on the ovaries themselves to produce problems with fertility. Okay. Some of it is weakly bound to albumin in the body, right? And most of these things that are bound to sex hormone binding globulin and things that are bound to albumin cannot be used in the womb. However, if there's an unbound portion which is called free testosterone, that is the portion that causes the problems with hyperandrogenism. Is that clear? Right? Now, how does the insulin fit into this? Right? So I will just tell you how insulin fits into it. If the woman has peripheral insulin resistance, or even type 2 diabetes mellitus, or glucose intolerance, the woman has it in a system. Okay. She has what? Because the peripheries are not doing very well with the insulin, right? And there's resistance. Then her free insulin, the pancreas will produce more insulin. And what does she have? Hyperinsulinemia. Okay. This hyperinsulinemia will do what? Will go to the liver, right? And reduce the production of sex hormone binding globulin. So when the SHBG drops, what happens? The portion of bound testosterone drops, and therefore the free testosterone goes up, right? So therefore, that is why in women with glucose intolerance, with diabetes and all that, there is an increased amount of women who also have polycystic ovarian syndrome, or features of clinical as well as features of chemical hyperandrogenism. Is that clear? You understand the relationship now, right? So therefore, in other words, right, if you give metformin, what happens? Peripheral resistance to insulin drops. Right? Therefore, it should improve the symptoms of PCOS. Got it? if you give, if you diet, then the features of glucose intolerance drops, right? And then features of hyperinsulinemia also drop, and that should increase the sex hormone binding globulin, and that will increase the or make the symptoms or clinical symptoms and signs of polycystic ovarian syndrome better. Is that clear? So it goes through that pathway. There are a lot of again, but I just want to simplify that for you to understand the relationship between insulin, sex hormone binding globulin, and free testosterone. Is that clear? Right. Now, we can measure the free testosterone, but that is not a very, very sensitive index. And also it is very, very expensive. Sometimes it's very difficult to enter. So usually, sometimes free testosterone does not really tell us, okay, is this PCOS? However, because we calculate the free androgen index, right? That takes into account the amount of sex hormone binding globulin as well. And how is it calculated? You divide the free testosterone levels, which you find in nanomoles per liter. You divide it by the amount of sex hormone binding globulin in nanomoles per liter, right? And you multiply the whole thing by 100 and you get an index. Okay, it's basically the ratio of testosterone to SHBG, right? Multiplied by 100. Is that clear? So this has found to have a better correlation or better relationship to our features of clinical features than just looking at SHBG or looking at free testosterone. Is that clear, children? Right? So when you ask, how do you measure features or clinical hyperandrogenism, you say two things. What are these? Free testosterone, right? What is the normal testosterone? Is 0.3 to 1.9, right? Anything over nanomoles per liter. Anything over that, right? Usually anything over 4, right, is very, very suspicious whether it might be something else. Anything over 2, remember, it makes features, the testosterone levels are high. Remember, these measurements and these values differ from lab to lab, okay, and from type of bioassay to type of biosphere. So always to interpret the results in the normal range of women and in ages, you have to look at the reference ranges. Is that clear? Right? Most of the time in most labs, the free androgen index is thought to be, if it is more than 6, it is thought to be elevated. Okay? If it is less than 6, it is considered to be normal. Some will take it as 6.5, some will take it as 5, some is right. But normally, if it is high, then there is a problem with the there is hyperandrogenemia or biochemical hyperandrogenism, right? Remember, there's something that you need to understand. If the free testosterone are very high, over 4 nanomoles per liter, it may be a tumor that is producing this, right? And if there are features of virilism, which is different from hirsutism, you need to be warned that it may be an androgen producing tumor. And especially if the features of virilism have come recently, all the alarm bells in your head needs to go off. What are the features of virilism? 5 features of virilism. What are they? Number 1, male pattern balding. Male pattern balding is balding from here. Okay? Alopecia is from the middle onto both ways in women. Okay? Male pattern, that is androgenic alopecia. Here is male pattern balding. 2, breast atrophy. Right? 3, increase in muscle mass. 4, clitoromegaly. Okay? 5, voice changes. It becomes deep like a man's. Okay? Because there's hypertrophy. Got it? So if there are features of virilism, especially early onset, please remember you need to really examine this one and do the necessary imaging to find tumors, especially in the pituitary and the hypothalamus or anywhere else. The ovaries, whether they are androgen producing tumors which are maybe malignant. Okay? Right. So that's just a small thing which I deviated. So remember what I told you. So then if these levels are not elevated, there is another step which you can do is to look at the pro-androgens, right? Or so pre-androgens, before testosterone, right? In the pathway before testosterone, there are two other important androgens. What are these? Androstenedione and dehydroepiandrostenedione sulfate, DHEAs, right? For you all, don't worry too much. There are very subtle things. Only thing you need to understand is if you want to look at the androgen profile, the best are what? Two things: the free testosterone level and the free androgen index. And I told you how to calculate and the norms. However, if they want to go deeper, you might need to have a look at the other things like androstenedione and dehydroepiandrostenedione sulfate. However, these are necessary to differentiate different times. Sometimes there are other conditions that might look like this, but not this, right? So different kinds of syndromes where you will need to do a big differential diagnosis. Those are needed, and for experimental purposes, study purposes, which you can do. Normally, we will not do androstenedione and DHEAs in a normal patient, but that is possible if you want, but they are expensive. Got it? It will not give you additional information and additional way of managing your patients. So therefore, probably this will be best left alone if you want to do a proper differential diagnosis and look into other syndromes, which probably is postgraduate and not undergraduate. Is that clear? Right. So those are the things that you need to look at when you are there. So now what we have done is what? We have done two, right? We have done what? As a summary, we have done the menstrual irregularities and what they are, and we have done the hyperandrogenism, and that is clinical and biochemical, right? Clinical, remember, acne, oily skin maybe, hirsutism. I told you what hirsutism is, and it's measured by the Ferriman-Galloway and modified Ferriman-Galloway score. And then we have what? Alopecia, which is normally checked with what? The Ludwig scale, correct? Right. And then we have biochemical hyperandrogenism. And how is that measured? Free testosterone, normally 0.3 to 1.9, right? And over 4 alarm-based monitoring, right? Or free androgen index, which is what? 100 multiplied by testosterone divided by SHBG in nanomoles per liter, right? And usually the index should need to be what? Less than. Some will take 5.5, some will take 5, some will take 6.5 to be normal. Over that, we are having, it shows that the androgens are, there is biochemical hyperandrogenism. Is that clear, children? Right. So the next thing that we need to do, one other feature for diagnosis, ultrasound, right? And so when you look at it, if you see polycystic ovarian morphology, okay, morphology is what you see, then one of the features of diagnosis. However, not essential, but, and what are these? If there are follicles or eggs between 2 and 9 millimeters, right, and over 20 of those, earlier it was different, over 20 of those in the ovary, or if the ovarian volume is more than 10 milliliters, okay, either one or both, right, that means it's a polycystic ovarian morphology. Is that clear? Right? So the ultrasound features would mean what? 20 follicles between 2 and 9 millimeters, that is under 1 centimeter, okay? More than 20, or if the ovarian volume is more than 10 ml, then that consists of polycystic ovarian morphology. So that is enough for you to understand the ultrasonic features. You don't need to know the small subtle things. So those are the 3 ways in which you make the diagnosis. Is that clear? Right? Okay, good. So let's move on. Hold on. Right, okay, fine, sorry. Right, where were we? Right, now, the next group of women that you can present to you are women who are menopausal. Okay, this is one group who will present. How do these women present? These women will present you after menopause with features of hyperandrogenism, right? Because they have had polycystic ovarian morphology, but the ovary continues to produce androgens. So, but because the ovaries have stopped producing the follicles, because the estrogens counteract the androgenic effects. Okay. Now, suddenly the estrogens are no longer there, but the ovaries continue to produce because of the polycystic ovarian morphology, right? Androgens. And therefore, when they become menopausal, suddenly they start to have beards. Have you seen those? Right? Elderly women coming to you, look, I've started to grow a beard or a mustache, and there's more hair on my body than it was. It's basically women who have traveled through life with polycystic ovarian syndrome, right? And suddenly when the estrogens drop, in the postmenopausal age, they start to have these symptoms. But you need to be very careful because these can be androgen producing tumors. So and you need to assess their free testosterone, free androgen index, and maybe imaging, and look for features of virilism, and then assess them that way, because you can, otherwise we might be missing an androgen secreting malignant tumor. Is that clear, children? Right. So now let's go to the next portion of it, right? Now, why are we worried about this polycystic ovarian syndrome? And what are the things that what are the problems that it causes for women with this condition? Number one, it causes, or it is coupled, and it may be coupled with the cardiovascular risk or cardiovascular disease, right? How is it coupled? Because most of these women can be obese. Now, what is obesity or overweight? Any BMI over 25 is considered by the WHO criteria as being obese, okay? Overweight. However, remember, in Asians, what is considered in Asians, it is thought that we should be at a lower. Anyone over 23 in the BMI is considered overweight. So remember, it might not be exactly the WHO criteria. So now for Asians and Southeast Asians, that BMI has dropped a bit. Also, what has come into consideration with cardiovascular, the waist circumference. For Asians, it is not only the BMI, right? Because there is the waist circumference is also calculated. So all these coupled together, in women with polycystic ovarian syndrome, if they also have diabetes, if they are overweight with the BMI of over 23, if they have hyperlipidemia, if they have hypertension, right, coupled with PCOS, the risk increases for cardiovascular disease. Is that clear? What does that mean? We will need to advise the woman who comes to us and we diagnose as gynecologists as having polycystic ovarian syndrome, if they are overweight, if they have hypertension, if they have hyperlipidemia, okay, and if they have diabetes, or if they have glucose intolerance, okay, and if they have all or some, and if it is coupled with polycystic ovarian syndrome features, this taken together for the PCOS woman increases their cardiovascular risk of having a cardiovascular incident. Is that clear? So you need to advise them. Get their lifestyle modifications, get their lipids under control, control their weight, have lifestyle modifications, control their hypertension, and control their diabetes or glucose intolerance. Is that clear? You all understand, children? So therefore, it is extremely important for you to understand that the PCOS coupled with these problems will increase the cardiovascular risk. So you have to tell that to them, right? Then remember, if a woman has gestational diabetes, okay, the risk of cardiovascular disease increases 5 times in women who is having PCOS against the women who do not have PCOS. Is that clear? Say if a woman comes to you with PCOS and you diagnose it, and if she has gestational diabetes, right, the risk of a cardiovascular risk is 5 times more than a normal one without PCOS, and that is in Asians. In Americans, 4 times. In Europe, 3 times. Right? Okay, 5 4. Okay. Asia, America, Europe. Okay, so that is something that you need to think about. Okay. Right. So, what are the other things that you need to consider? Next one is, what you need to consider is the chances of sometimes what we call obstructive sleep apnea increases in these women. What are these? What is obstructive sleep apnea, children? Obstructive sleep apnea is because these women may be obese or has a higher BMI, right? Sometimes there can be an increased incident of obstructive sleep apnea. Okay, so this is not for us to treat, but we will need to assess that, and if they have very difficulty in sleeping, and if they get up feeling not refreshed at all, okay, and they have, when they get up they feel very sleepy and tired and not feeling good, then we have to assess what we call obstructive sleep apnea. That PCOS, it is thought that they have a higher incidence of obstructive sleep apnea. And how is that measured normally? There's a questionnaire for, we don't need to discuss that, but it is called the Berlin tool. Berlin in Germany, BERLIN. Berlin tool, it was developed there, right? And those, there are several questions we need to ask. Tick, 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 and you will say, okay, this patient probably has obstructive sleep apnea. Then we will have to send them for sleep test, right? OSA test, and then a specific therapy will have to be initiated for them to think about obstructive sleep apnea. Okay. Then, what is the other risk in PCOS in women? Why is it important? Endometrial carcinoma is increased in women with polycystic ovarian syndrome. Why? Because there's an increased production of what? Estrogen. And an increased production of estrogen will thicken the endometrium all the time. And there is no, it does not convert from a proliferative phase to a secretory phase. So there's always a constant bombardment of estrogen onto the estrogen. So what does happen? It thickens the endometrial thickening. So it is pushed into hyperplasia, and that can be pushed onto what? That can be pushed onto the for the woman to have endometrial carcinoma. So woman having polycystic ovarian syndrome for a long time, right? And that risk is more in the perimenopausal age than in the postmenopausal age. Because in the postmenopausal age, the ovaries stop producing estrogen and she stops to have her periods. Okay. So there are no estrogen stimulation on the endometrium. Therefore, postmenopausal, the risk will drop. But women in the perimenopausal age, the risk of they come with very thickened endometrium. Then if we sometimes with irregular bleeding, when you do a biopsy, we might find endometrial hyperplasia or endometrial cancer. So there is one very important, there are no ways in which we can thin out the endometrium other than giving medication. No, but there is no specific reason for us to check for endometrial carcinoma in polycystic ovarian syndrome patients. But you need to keep in mind, if they come with persistent bleeding and they are also diagnosed with PCOS and the endometrium looks very irregular, then of course an endometrial biopsy is indicated, right? Then the next important thing with with polycystic. Now, if we look at what have we looked at, children? Yes, tell me, Dushani. I'll ask you a question because I can see you. What are the problems that we have looked at?
Cardiovascular.
Cardiovascular. What?
And then the obstructive sleep apnea.
Okay, right. That is not that important, but yes. Third.
Then the endometrial carcinoma.
Risk of endometrial carcinoma increases. Yes, possible, but that is, remember, in the perimenopausal age. Next one. We missed something very important. In CVD. No, remember diabetes, right? Risk of type 2 diabetes can, if the woman has has diabetes, it also increases the cardiovascular risk in patients with PCOS. And on the other side, PCOS can increase the chance of glucose intolerance as well as increase the chance of type 2 diabetes. Because type 2 diabetes, women with type 2 diabetes has an increased risk of developing polycystic ovarian syndrome problems because due to what? Insulin resistance causing hyperinsulinemia, which in turn will cause problems with sex hormone binding globulin and the internal milieu of the ovary as well, right? Those are two things, right? So that is the summary up to now. Now, what is the next most important thing which we have to assess in polycystic ovarian syndrome? It's a quality of life. There are lots of things, a lot of areas that you need to consider when you look at the quality of life. The whole huge chunk of it is about the assessment of the quality of life and what can go wrong in the quality of life. In PCOS, there's a special questionnaire, right, which you need to know the name only, but you can look it up if you want. It is called the PCOS Quality of Life Score. Polycystic Ovarian Syndrome Quality of Life Score. Right? Okay. So this, in several questions or in several sort of areas, will measure the quality of life of a PCOS woman. It's called the PCOSQ. Okay. And that is one way in which you measure. Now, what are the areas that you look at, right, in this PCOSQ? So these are the questions you need to ask. Number one is the woman may have a very bad body image, right, about herself, that she is obese, she does not look well, she is not attractive, other people think of her as fat or overweight, right? And cosmetically she doesn't look good. So they have a some of them will have a very bad body image. So this is something which we can assess with several questions in the PCOSQ. Is that clear? That is the first area that you need to understand. Got it? The second area is that these women psychologically can be depressed, very worried, depressed. Okay, so they are anxious, depressed, and they always keep thinking about themselves. Okay, am I eating too much? Am I not eating the right food? Why am I not exercising? Why am I not doing this? So these are women who are having problems with They may be depressed or anxious or having problems with their day-to-day life because of the anxiety and the problems which they have. You understand? So that is the second large area, problems with body image. That is of course interwoven with psychological problems as well. That is the second thing. Okay. The third thing is these women may present to us with problems of or eating disorders, right? What are these eating disorders, right? It can be overeating and then that's called bulimia. They vomit it out. And how is it assessed? Eating disorders are assessed with what? It's called the SCOF. Have you heard of it, children? I think you all would have been taught in psychiatry, right? It's called the SCOF way of assessing. What are these things that you need to assess? S is whether they become sick. What does that mean? After they eat, they will put their fingers in and vomit. Okay. So do they make themselves sick or vomit after eating? Right? S. C is whether they are always trying to control their food. Every time they want to, okay, I want to control it. I want to control it. I don't want to eat this. I want to eat it. So every time you think of it. Okay. That is C. O is one. Actually, it is an English abbreviation. O means one stone. What is one stone? Is the way you measure things in the English system. Stone, right? However, it is equal to about 6 to 7 kilograms. So have you lost about 6 to 7 kilograms in the past 2 to 3 months, right? By causing themselves to vomit. That is O, one stone, right? F is whether they are always thinking of food or problems with food. Am I eating too much? Do you understand? And the other F is fat. F for fat. What does that mean? Although they may be very thin, they are always thinking they are fat. Although the other people think, oh, look, you are thin. No. In her mind, she is fat. You understand? So if you are looking at these 5 problems, right, or this questionnaire of SCOF, S, C, O, F, F, right? This woman may be having a eating disorder. Is that clear, children? Right? So therefore, this is one way which you need to assess the eating disorders, and then you will need to send her to the relevant person, psychiatrist, specialized people to treat her. Is that clear? Got it? So that is the, so what have you told on the quality of life? One is what? Assessment overall is with what? PCOQ. Is that clear? Polycystic ovarian syndrome, quality of life assessment, right? That is a question. Got it? Second big problem is what, children? They may be having what? Yes? They may be having psychological problems, right? Which may be assessed with different questionnaires and different. The commonest questions that you ask, are you not feeling good with yourself? Have you been depressed lately? Are you not going about your normal day-to-day activities? Do you find it very difficult to do what you usually do, right? Are you feeling like you don't want to go on at all, right? Those are the things which you assess. So these are the simple questions. If they say yes, 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 then they need proper psychiatric evaluation. Okay. The third thing that you have to do is what? Psycho, then body image, psychological problems, then the psychosexual problems, right? What are the psychosexual problems? If they have problems with sexual intercourse or sexual interaction with other their partners, right? Due to this problem, right? Then they have psychosexual problems that will require very good input from the psychiatrist as well, right? So what is the other thing which I told you? Four problems which I told you about: psychosexual, psychological, eating disorders, and what is the fourth thing? Yeah, yes, Dushani?
Problems in body imaging.
And body image. So those are the things which you will need to assess children in a woman who is having polycystic ovarian syndrome to assess the quality of life. Is that clear? Got it? Right. Okay. So give me one moment. I need to just take a quick call. Give me a moment. Huh? Right. Okay. Now, sorry. So now we have assessed the patient with polycystic ovarian syndrome, right? Now, what are the main problems now that the women come to us with? Number one, they come to us mainly with infertility. Okay. The second problem is they come to us with menstrual abnormalities. Got it? Right? The third problem they might come to us is with what? Problems, cosmetic problems, which I just spoke to you about. Right? So that is how we assess a patient. Is that clear? That's all. Then the next thing, remember, just assessing menstrual irregularities coupled with features of clinical hyperandrogenism or our investigations of clinical biochemical hyperandrogenism, right? And then there may be assessment of infertility as well for that patient. That is the male and the female partner, right? Is not enough. Okay. Plus, you need to assess what? The cardiovascular risk, the risk of diabetes, sleep apnea, the possibility of sleep apnea, then the quality of life. What are these? Eating disorders, psychosexual disorders, psychological disorders, and what the other thing? Body image. Do you understand? So this gives us a total understanding and a clinical picture of the patient with polycystic ovarian syndrome. Is that clear? Is that clear, children? So it is not just asking, okay, acne do you have acne? Do you have, are your menstrual problems are there? No. These are the total assessment which you need to have, make a note of. Please, as MBBS students, remember when you are taking a history from the patient who you think is polycystic ovarian syndrome, please make sure that all these areas are covered and they are presented depending on the case. Is that clear, children? Right. From there onwards, we'll move on to three specific areas very quickly. Right? What are these three specific areas? How to change this or make the patient better? Number one is we have patients who are treated without problems of infertility, but for features of hyperandrogenism and features of abnormal or menstrual irregularities. Okay, that is number one. Then there will be a cohort of patients who is getting treated for infertility, right? On top of that, that is the second type of patients we need to manage, right? And the third kind of patient is, okay, so those are the main areas that we need to manage, right? For both these kinds of patients, fertility as well as patients who have no problems with fertility and patients with problems with fertility, there is a common ground in which we need to advise all these patients with, right? What are these? Lifestyle modifications. Is that clear? So that is something we need to advise each and every patient with polycystic ovarian. So in whatever answer you write, children, for what it is, lifestyle for polycystic ovarian syndrome, put in lifestyle changes. Is that clear? Right? So what are these lifestyle changes? Number one, weight loss. That is the most important, single most important in patients with polycystic ovarian syndrome and who are overweight. Okay, that is the single most important thing. And how do we go about advising them? It's called SMART. How do you advise them to lose weight, right? You just don't say, oh, look, go and lose weight. So you need to give them something which is what? Which is achievable, right? So it has to be, one is it has to be a very smart way of doing it. So it has to be in small amounts. Okay, so it has to be very, very specific. Try and lose this amount of weight in this amount of small. So that is the S, right? Okay. Then it has to be measurable. You have to be able to measure it. And how do you measure it? By waist circumference, by looking at the getting a scale and measuring it at regular intervals. So that weight loss needs to be measurable. Okay. The next is we need to set them achievable targets, things that they can, really. Okay. Say 2-3 kilograms in 2-3 months. Is that target achievable? Doable. If you ask them, look, you are 30 kilograms overweight, go and lose it and come. Are they going to do it? It's impossible. You understand? So, so it has to be specific. Do this. It has to be measurable. Please lose this amount, and you need to measure the way you are losing it. It has to be achievable. Do you understand? And it has to be realistic. The patient needs to be able to think that it is going to what? That it is going to be possible. Because if you just ask one of these patients to just go and lose weight, this amount, they are never going to do it. Right? So it has to be really, really, and it has to be timely. So it needs to fit in with whatever her lifestyle is. You understand? So you have to give them the way out. So this is normally achieved not by a gynecologist, right? So yes, the system must be smart, right? Specific, it has to be measurable, right? It has to be achievable, right? It has to be realistic, and it has to be timely. So that is what it's called smart way of losing it, right? So there is nothing specific where you can have all types of diets. Nothing is more better. One is not better over the other. There are thousands and thousands and thousands diets where people try to lose weight, right? But however, realistic goals must be given. And what has been found is if the woman is encouraged to lose 5 to 10% of her body weight, that is more than enough for her to achieve a better body image, for the psychosexual problems, for her psychological problems, and sometimes maybe behavioral problems or food disorders, but that of course is a different kata. But to achieve fertility, to achieve fertilization, for pregnancies, if the woman is given a target to lose 5 to 10% of her body weight, that is very much it can help her to lose or reduce the problems with polycystic ovarian syndrome. So if a woman is say 100 kilograms, and if you ask her to lose 5%, what is that? Just 5 kilograms. Okay. So we are asking her to reach 95 to improve her symptoms and problems. Is that achievable? Yes. 10%? Very good. For a 100 kilogram woman, if you lose 10%, what is that? 10 kilograms. See, we are asking her to come down from 100 to 90. Do you understand? So that is the way which is. So the dietitian, we need to direct them to a dietitian for them to achieve that. Okay. Now, scientifically, what do we do? Scientifically, if you are looking at the diet, we are trying to create a deficit in the calories. And what is the amount of deficit that we are trying to create? We are trying to create a deficit where the intake of calories is less than the what? The amount that she the intake is less than the amount she is spending, and we are trying to give her a deficit of about 30%. So the daily achievable daily activities calculated. Okay, so Monday I am going to do this, I will do this, and then the amount that is spent in kilocalories are calculated by the dietitian. Okay, and then what they do is they will try to fit a diet into an amount that is about 70% of what they spend. Is that clear? They are reducing the intake to match the amount they are spending, right, by about 30%. So usually it is a reduction of some amount of kilocalories. It will range from about 400 to 500 kilocalories per day. What does that mean? The amount you spend in your activities, right, in kilocalories, right, will be more than what you take into your mouth. So what happens? There is a calorie deficit, and with time, what goes on? She will start to lose weight gradually. So that is the scientific basis of losing weight. So if the woman eats more than she spends, then definitely the rest will get accumulated in her. And what will happen? She will become overweight, BMI will increase, and then the polycystic ovarian syndrome will worsen, and so will all the rest of her problem. Menstrual irregularities, features of hyperandrogenism, infertility, psychosexual disorders, right? Body image, everything will go for a 6 depending on that. Do you understand? So that is the scientific basis on it. So if you ask, okay, why do you diet? What are you trying to achieve, children? You are trying to achieve a 30% deficit between intake and output, right? Which is usually about 500 kilocalories, and that will gradually. So it needs a lot of control and a lot of good advice for a woman to achieve that, right? The second most important thing is exercise. And how do we do not ask them to go and do massive exercises, and so that they will hurt themselves, and so what is the normal moderate amount of exercise that we advise? It is called, for women, for adolescents, it's about 60 minutes, 2 to 3 times a week. 1 hour, 2 to 3 times a week, or 3 times a week. So if a girl has polycystic ovarian syndrome and has problems, we ask them to exercise along with diet, right? About 30 minutes, right? 2 to 3 times a year. That is what we do. If it is a woman who is not an adolescent, right? Not a teenage, then what is the requirement? It's 150 minutes per week in 2 to 3 sessions of non-intensive exercise, or 75 minutes intensive exercise, right, per week in 2 to 3 sessions. Do you understand? So that is what we just ask them to do. And that, coupled with diet, will give them a weight loss and improve every aspect of their quality of life, right? In a woman who is having problems with all the things that we spoke of. Is that clear? Right? So this is something that we have to advise them. So it's very easy. We have if you are talking about lifestyle area, there are two large areas, children. What is what? Diet and exercise. And of course, diet means what? You need to go for a 30% or around 500 kilocalories of deficit, right? So basically the woman will be eating somewhere around 1200 to 1300, 400 kilocalories per day, but she needs to exercise, right? So that she creates a deficit and that causes her to lose weight. Okay. So that is the lifestyle changes that we are advising her. Got it, children? So that is for everyone, for patients with fertility and patients with infertility. Okay, so no fertility problems and patients with infertility. Is that clear? Next, we switch on to what? The management of these problems, which is pharmacological management. Okay, pharmacological management is like this. So let's take first women who comes with menstrual irregularities. So remember, lifestyle modifications as well as exercise is going to improve all these problems, right? On top of that, if she desires or if it doesn't help, then we have to go for pharmacological management. In the first group, let us take women who are having no fertility wishes, but they want to sort out their menstrual irregularity. The first thing, the first most important thing is what? Combined oral contraceptive pills. That is first line in the treatment, and that has shown us the best results, because what it does is it gives a low dose estrogen progesterone throughout. Then, because of the negative feedback on the hypothalamus pituitary axis, because of the presence of estrogen and progesterone in the blood, the brain thinks that there is estrogen and progesterone in the body, and therefore it does not send out FSH and LH, and there is no hypothalamus pituitary stimulation of the ovaries, and therefore the ovaries become inactive, and all the hormones are given to us by very low dose estrogen progesterone combined pills, and that will increase the thickness but not too much in the endometrium, and then at one point you stop. So there are no ovarian hormones and the external hormones stop, and there's nothing to control the sustain the endometrial, small endometrial growth that happened with the low dose estrogen progesterone. Do you understand? And then it breaks away, but then the flow will be small. Then after 7 days, again you start low dose estrogen progesterone for 21 days. Then you stop and it breaks away, smaller. Then again 20. So 21 days on, 7 days off, 21 days on, 7 days off. If the woman wants a period once in 63 days, she can do 21 active tablets, another 21 active tablets, another 21 active, and stop. And then she gets a bleed. So those are withdrawal bleeds. Those are not periods or menstruation. You understand? So combined oral contraceptive pills has the best action in controlling the menstrual irregularities in women who do not desire fertility. Is that clear? At the same time, because of the action on the sex hormone binding globulin, right? The features of hyperandrogenism also becomes better. So they will have less acne, they will have less hair, right? Hirsutism, right? On top of that, they have a good cycle. However, that might not be enough for all women. Okay, so after giving about 5 to 6 months, right, and still if the women in combination with the menstrual irregularity is not very happy with the effects of hyperandrogenism, okay, you can combine this with anti-androgens. What are these anti-androgens? Anti-androgens are mainly cyproterone acetate. Right? Do you understand? So combined oral contraceptive pills alone will give a good answer to the menstrual irregularity. Got it? However, it might not be enough for the woman to help her with what? Her features of hyperandrogenism. Okay, and therefore at some point there is a possibility that you might need to combine it with anti-androgens with that. Anti-androgens can be given as a standalone drug, cyproterone acetate, in combination to combine oral contraceptive pills. Is that clear? So the oral contraceptives go on for her menstrual regularity, and you give on top of that anti-androgens to control the other features like acne, hirsutism and all. The second problem option is there is a combination of estrogen or ethinyl estradiol with cyproterone acetate. So that combination will give the woman a way of combating menstrual irregularity with what? With features of hyperandrogenism. Is that clear? However, it needs to be taken for a long time, 9 months, 12 months, until these things like anti-androgens or cyproterone acetate is the commonest, can start to work on the hair. Because what it does is it works on the follicles. So already pre-existing terminal hair is not going to change. It basically does not, what it does is it keeps the vellus hair turning into terminal hair. You understand? So for a terminal hair to fall off, it takes 6 to 9 months pre-existing. And therefore the effect will be seen only after 9 months to 12 months after starting cyproterone acetate. Is that clear, children? If the woman wants control for her hirsutism before that, she will need to use mechanical methods, which is used. And all our ladies will definitely know all the mechanical methods where you have this, I don't know, threading, shaving, electrolysis, which might be permanent, removal of hair, I don't know, eyebrow plucking, all those things, right? And shaving and all those things, which are the ways of hair removal, and especially the terminal hairs are targeted because that is what causes embarrassment and hirsutism. Remember, but it is ethnicity dependent. So in some countries, even the smallest amount of terminal hair may be considered as having hirsutism, while in some countries it might be absolutely normal and beauty is combined with having a few hairs here and there. You understand? So therefore, it is very, very dependent on the country which the woman is living in and where you are working. Clear, right? Do you understand? So then, so you can combine oral contraceptive pills as well as you can combine anti-androgens, or you can combine both together. And however, these combined pills, estrogen with cyproterone is not a contraceptive. So there is a possibility you might get pregnant on that. So you have to warn the woman. So you cannot use it as a oral contraceptive pill at the same time, right? So she will need to use other methods for her contraception, maybe a loop or a Mirena or a copper IUCD or whatever, in combination with this, which is trying to combat her problems with her menstrual problems and her features of hyperandrogenism. Is that clear? The next thing which you have to understand is that how do we use metformin, right? And does metformin improve features of menstrual abnormalities, and does it improve features of hyperandrogenism? Metformin is useful, and there's a lot of evidence now, right? Earlier there was some evidence, then there was thought to be ineffective, but now again the the metformin is coming into play, and therefore metformin can be used in combination to oral contraceptive pills, in combination to cyproterone acetate as an individual agent that will have an effect on the polycystic ovarian syndrome. By what? By changing the peripheral insulin resistance into causing the peripheral tissues to be more sensitive to insulin. And that reduces hyperinsulinemia, and that reduces the reduction in sex hormone binding globulin. Insulin වැඩි වෙන්න sex hormone binding globulin එක අඩු වෙනවා. Insulin අඩු වෙන්න sex hormone binding globulin එක වැඩි වෙනවා. Sex hormone binding globulin එක වැඩි වෙන්න උන්ගිල්ල මොකද කරන්නේ? They will combine the free testosterone into bound testosterone. That will reduce the features of hyperandrogenism. Do you understand the logic, children? So therefore, metformin can be used in any dose. Initially, you can start with 500 daily, 500 twice daily, up to 2,500 milligrams a day, right? Depending on what you want to do. Is that clear? So it can be used in combination as well. Okay? Right. Give me a moment. Sorry. Okay. Now, where were we? Where were we, children?
Metformin.
Right, okay. So metformin can be added initially. So you can start off with oral contraceptive pills, and if you want, you can add an cyproterone acetate or anything, or a combination of that if the problems are with fertility. At the same time, you can add metformin if you want, or if oral contraceptive pills have been tried with lifestyle changes and it is not very effective, or the woman is not pleased, then you can add metformin 5 to 6 months later if you want. Do you understand? So those are the ways which you can treat it. Now, we have discussed oral contraceptive pills. We have discussed, one moment. Okay, children, where did we stop? Which part did we stop?
We can combine the lifestyle modification and COCP with the metformin.
All right, okay. So I told you how metformin can be used, right? It can be used later on, can be added on, or can start in it. Now, there some now if a woman has alopecia, what do we do? Alopecia is thinning of the hair, right? I told you there's a score which we assess it. It's what is that called? It's called a Ludwig score, right? So where it's assessed. So for women with alopecia, of course, you might need to start anti-androgens, because alopecia is directly most of the time related to the androgen or testosterone that works on the follicles of the hair in women, and then they start to fall off, right? So therefore, you have to start anti-androgens, and it's usually started in combination with an endocrinologist or a dermatologist, where they will assess everything and start this, right? Got it? Then there are several drugs which are used in these women, which are still not much evidence. One of these is called inositol, right? Which is used, but maybe things will later will come up with what is this? Some evidence will come up, but for the moment there is not an overall increase in level of evidence for us to use it routinely. It is used in experimental trials. Few trials are coming up, but it's for the moment it's not shown anything sort of huge for us to use it on a daily basis. It does not come up in any of the guidelines for the moment, right? But keep in mind that the inositol might be a drug we might need to look out for in the future. Plus, there are several other drugs that are coming in. So management of PCOS might change depending on the drugs which are coming into the market. Okay, so that is something that you need to keep in mind. But for you all, of course, please remember how to treat each of these in women who do not have fertility issues. Okay. The next important group are the women who wants treatment for fertility. And the biggest problem in fertility is anovulation. So what we do is we do things for women to have ovulation. Okay. So remember, this is always in combination with all the things that do not have an effect on ovulation. What does that mean? We can do cosmetic procedures for features of hirsutism. Okay. They have to have lifestyle changes, which would mean diet and regular exercise, right? They will, I have forgotten one thing which actually we will do now is what? Psychosexual and behavioral problems needs to be assessed with a psychiatrist or somebody with special interest in them. Okay, so I forgot. So therefore, all psychosexual problems, psychological problems, depression, right, suicidal ideation, then all these must be managed with an expert in that field. It might rarely, there may be rare use of antidepressants, which is a possibility. Okay. Then there is cognitive behavioral therapy, where different kinds of therapeutic cognitive behavioral therapies are used to improve their body image, to improve their response to diet and exercise, right? So that one, cognitive behavioral therapy, is used to increase or facilitate women to try and better their body image, psychosexual problems, and depressive problems. Do you understand? All that, all right, will increase the chances of her settling her problems with that. So do you understand? So that also comes in the mainstream therapy as well. Got it? So now fertility problems, if you are going to address that, remember all that what I told before needs to come into the picture, plus we do things for ovulation. Is that clear? Right? So when if you're going to talk about fertility, please talk about lifestyle modifications, behavioral modifications, right? Diet, what the aims are. Then you have to talk about exercise, what the routine should be, right? On top of that, if there probably is body image, then you have to talk about the cognitive behavioral therapy strategies, involvement of the psychiatrist, dietitians. Do you understand? Plus, we have to think about ovulation. So the first most important thing which you have to remember is there are first line drugs which we use for ovulation induction. The first line that is recommended now is letrozole. Okay, it is not clomiphene citrate anymore, right? And letrozole is a aromatase inhibitor. And what does aromatase inhibitor do? Aromatase is required, right, for the peripheral conversion of androgens to estrogen, right? So what it basically does is it causes a deficit in the estrogen in the periphery. Okay, so it's an aromatase inhibitor. So what aromatase does is it converts the androgens and all from the peripheral tissues into estrogen. So now when it blocks it, in the periphery there is a what? There's a estrogen deficiency. What does the brain think? Okay, there's not enough estrogen. And what does the brain do? It increases FSH and LH. Okay. So therefore, it does not act on the central axis. It acts on the peripheral. And that causes a very controlled release of FSH and LH. Okay. So therefore, the other interesting thing is letrozole does not act too much on the uterus itself. If it acts on the uterus itself and it causes a reduction in the estrogen there, what happens? The layer of the endometrium, right, will not thicken too much. Do you understand? And if it doesn't thicken too much, what happens? The baby cannot implant into the endometrium. So it is very important when ovulation occurs, the endometrium is of sufficient thickness to receive the baby. So it doesn't thin out the endometrium. At the same time, it causes a estrogen deficiency in the periphery that causes the brain to think that there is a estrogen deficiency and put out FSH and LH, especially LH. And what does that happen? It is a near normal mechanism, and therefore you have monofollicular ovulation. One egg. Got it? So therefore, it is thought now, because multifollicular, if there are a lot of follicles, right? What is the danger when you do that? There can be multiple pregnancy. At the same time, there can be hyperstimulation, which is a complication. So the two complications of hyperstimulation is what? Two complications of multiple stimulating the ovaries is hyperstimulation, right? Ovarian hyperstimulation syndrome, OHSS, and multiple pregnancy, right? Do you understand? So that is not there, or very rare. So therefore, letrozole is found to be the first line drug. And how is it used? 2.5 milligrams can be started from day 3 to day 7 of the cycle, 2.5 milligrams daily, up to day 3, day 4, day 5, day 6, day 7. That is 5 days, up to from day 3 to day 7. And then you can check for ovarian follicle growth, and then you can do a you can give a human coronary HCG, coronary gonadotropin, for ovulation, and then you can do either natural intercourse, time natural intercourse, or you can go with intrauterine insemination, and so on and so forth, right? The second agent that we need to talk about is second line. Now, although it can be used as the first line also, which we are using for London, is clomiphene citrate. Now, what does clomiphene citrate do? It basically is an estrogen blocker. And what does it do? It goes on, it blocks estrogen receptors, right? Centrally, most of the time. It goes into the brain, and in the brain, in the hypothalamic region, it blocks the estrogen receptors. Okay, so it acts centrally. And what does that do? When the estrogen receptors in the hypothalamus is blocked, the negative feedback of reduction in estrogen, right, is not there. See, when there is enough estrogen in the body, the hypothalamic receptors it'll go and combine with the hypothalamic receptors. And what does it do? Okay, there's enough estrogen in the body, so no FSH. If there is no, right, if there is no stimulation, or if the receptors are not working properly, then the brain suddenly thinks, okay, there's no estrogen. So what does the clomiphene citrate? It goes and blocks these receptors. So the brain thinks, nothing is coming, no stimulation. And therefore brain thinks there's no estrogen. And what does it do? It increases the production of FSH and LH. Do you understand? Got it? So the negative feedback is cut off, right? And the brain thinks there's no estrogen because it blocks all the receptors. And therefore, the FSH LH, and then it causes the ovary to increase follicle. But that can give what? Hyperstimulation or OHSS, and it also can give multiple pregnancies. In letrozole, the doses you can start from 2.5 daily to a maximum of 7.5, not 75, 7.5 milligrams daily up to 5 days. Do you understand? 2.5 daily or 2.5 PD or 2.5 3 times a day for 5 days. So each cycle you can step up if the desired result is not there until 7.5 milligrams a day for 5 days. Is that clear? Clomiphene citrate, now the new is you can go maximum up to 100 milligrams a day, right? So you can start with 50, you can go to 75, or you can go to 50 and 100, but 100 is the maximum. There's no point in increasing further. So therefore, you can go up to 100 milligrams a day up to 5 days. And that is usually given from day 2 to day 6. Is that clear? So both for letrozole and for clomiphene, its action can be potentiated and may be better if you add metformin to the cycle. Okay, so you can use clomiphene citrate alone or in combination with metformin for ovulation induction. The results are better. Okay, so you can use clomiphene citrate alone and wait for a Silva cycle. If that is not doing much, then you can add metformin, or you can start with clomiphene citrate plus metformin for infertile patients. Okay, you can start with letrozole alone, or you can start with letrozole and metformin. Okay, in some countries, metformin is given alone as a way of ovulation induction, right? But normally now it is not very much practiced because clomiphene citrate as well as letrozole is superior to metformin alone as a ovulation inducing agent. Clear? So there's no point in giving metformin alone. But however, in patients who cannot take letrozole for some reason, for its side effects, who cannot take clomiphene citrate, metformin alone is an option for ovulation induction. Is that clear? But mostly what we do is we combine metformin either with clomiphene citrate or letrozole for ovulation induction. Is that clear? The next one, which can be used alone as a ovulation induction agent, is what? Gonadotrophins. Right? Gonadotrophins can be used alone without clomiphene citrate or letrozole and can be used as the sole agent for ovulation induction. It is more often used in IVF cycles, right? However, if clomiphene citrate alone was not good enough, or clomiphene citrate plus metformin did not give results, or if letrozole plus alone did not give results, or letrozole plus metformin did not give results, you can use, without using any of those, you can use FSH, right, as a sole agent for ovulation induction using different regimes, right? That is gonadotrophins can be used. Is that clear? At the same time, there are several regimes which we can use: clomiphene with gonadotrophins, letrozole with gonadotrophins, and to all that we can put in metformin as well. Is that clear? Right? But usually we don't use 2-3 agents. If letrozole has not worked to the maximum dose, if clomiphene citrate has not worked to the maximum dose, then you can take all those, but keep metformin and start with gonadotrophins alone for ovulation induction for whatever purpose. It can be timed intercourse after ovulation by HCG, or it can be if she can be going for intrauterine insemination, or she can be going for IVF. Is that clear? So there are lots of regimes, but it is FSH given in step-up doses, or usually 75 international days or 150, which you can give on certain days. You don't need to use regimes, but they can be used for ovulation induction. Is that clear? So those are the medications that are used for fertility purposes. And of course, there are different types that can be used, then GnRH, gonadotropin releasing hormones, can be used for IVF cycles. We do not use them for normal cycles, but for IVF, gonadotropin releasing agonist or antagonist can be used. Now, when you use an agonist, you have to start from the previous cycle. So you have to go for a long way to stimulate. That is the only thing you need to know, right? However, if you are using antagonist, right, you can use it in the same cycle. So it becomes a short cycle. So it doesn't need long stimulation, which has its advantages. So basically what you need to know is for IVF, gonadotrophins can be used, and GnRH analogs, agonist or antagonist, can be used for IVF cycle. That's all you need to know. Do you understand? So this consists mainly of the management of polycystic ovarian syndrome and how we manage problems with fertility and how we manage patients who do not have fertility issues. So that is basically what I wanted to teach you about polycystic ovarian syndrome, right? Is that clear? Right? did that make polycystic ovarian syndrome more clearer to you than being a rather dark area, right? So I think this should cover most of the things that you want to know. So it's 11:27. So what we'll do is we will wrap up. And do you all want me to do a question and answer session? Now it's too late, 11:30 now. In the next one, solely on polycystic ovarian syndrome, or shall we move on? What do you all think? Yes? Yes? Do you want me to do a obstetric topic next?
Yes, sir.
Yeah. So I think I would have answered almost every question that is there in polycystic ovarian syndrome, right? I don't think there's anything much left. There's one question. So PCOS you said as high estrogen. How does giving estrogen cause regular menstruation? Right. Okay. OCP. So OCP, it does not cause menstruation, right? What it does is combined oral contraceptive pills have low dose estrogen and low dose progesterone in combination, right? So therefore, what happens is when that is given into the body, it also goes and combines with the hypothalamus pituitary axis receptors, and that causes a positive feedback, and it tells the brain there is estrogen and progesterone in the body, and therefore it stops putting out FSH and LH, which stimulates the ovaries for the follicles to produce estrogen. So when there is no brain stimulation, the ovaries start not to work, no follicles, no estrogen. So the only estrogens that come is from the pills that we give the patient daily for 21 days. So the endometrium is quite thin, but it is there. At the end of 21 days, when you stop, no hormones coming from the ovaries and no signals coming from the brain. And the only ones we have given is from our OCP. And then the endometrium has no hormones and it breaks away. So that mimics a menstruation, but it is not a menstruation. It is a withdrawal. Do you understand? 7 days afterwards, most of the things have gone. Then you start again with oral contraceptive pills. And then again, 21 days on and breaks off. 21 days. So that is how a period or a menstruation is mimicked and not, it's not a real menstruation. I hope that's clear. Yeah. Is there a place for tamoxifen in it? Yes. Now, tamoxifen is also an agent which is a selective estrogen receptor antagonist or a modulator. Actually, it modulates the estrogen receptors into increasing the ovulation. So it can be also used, but now it has fallen into disuse because there may be other effects. So it's more being used in breast cancer because it modulates the estrogen receptors and blocks the estrogen receptors, especially in different tissues, and that causes an increase in ovulation. Yes, it can be used, but now it's not. Most of the guidelines nowadays are not using that. I forgot something. Yes, children, I forgot something very important. Is there a place for that? Sir, ovarian related only such. Now I forgot something. I actually, it's good that you ask the questions to complete this. If the clomiphene citrate does not work, if the gonadotropins do not work or it's contraindicated, if the lot of cycles, and if the woman is not in a place or is the ovulation or the ovaries cannot be monitored by ultrasound scan, ovarian drilling as a laparoscopic surgery is indicated. However, laparoscopic ovarian drilling has the same effect as clomiphene citrate or letrozole. It gives monofollicular ovulation. At the same time, if there is an indication at the same time to do something like adhesiolysis, removal of the cyst, treatment of endometriosis or anything like that, then of course laparoscopic ovarian drilling is an option than to just give ovulation in induction agents. Do you understand? That is number one, surgery. The second surgery which we have to talk about is bariatric surgery. I actually forgot to talk about that. When the BMI is very high, especially over 35, 40, right? One of the ways in which to treat these women are bariatric surgery, right? When bariatric surgery is done, there are different kinds, Roux-en-Y, and then there is a sleeve gastrectomy, different types of bariatric surgeries. What happens is everything in the woman improves. The weight goes down, the endocrine profile improves, the diabetes gets cured sometimes, right? And that gives fantastic results as far as fertility is concerned. Because these women who never ovulated started to ovulate again because of the drastic loss in weight. So therefore, if none of the other ovulation inducing agents are working, plus the fact if she is obese, the BMI is very high, has a lot of other metabolic syndrome problems, right? And especially diabetes and all that, bariatric surgery, especially in very overweight women with BMIs over 35, 40, it is definitely, sometimes over 30 even, it is definitely something that we need to think about. So those are the two other options which I forgot actually, the surgical options for treatment of infertility and of course for the reversal of all the other problems, even other than infertility. Question, do we use ovarian drilling for reasons? So I already answered that. So what is done is normally we give traditional way of talking about is 4 holes, 40 watts, 4 millimeters deep in 4 places. Now, how does it work? What it works is basically Stephen Leventhal, the 2 very important gynecologists, I cannot remember 1800s or so, I cannot remember exactly the dates, they worked as gynecologists. They found very large ovaries in women who are infertile. So what they thought was, okay, this is too large. Let's slice it up a bit and see whether it starts to work. And suddenly, so they started to, like a cake, they cut it and then sutured it and left it. And suddenly these women started to ovulate. And that is called wedge resection. Although the reason was not found, it was found to be effective. Now, what do they do? Because the polycystic ovary has a lot of follicles and a lot of stroma. And this stroma, because the ovarian volume goes up, remember the diagnostic criteria is more than 10 ml, right? So what happens is the ovarian stroma produces androgens, testosterone. So when you do a wedge resection, the mass or the volume comes down, and therefore the ovarian, the testosterone falls, and the features of hyperandrogenism falls, and that changes the increases the ovulation level because the local amount of androgens also fall. So the same thing now, we don't go chopping ovaries now. We do the ovarian stroma destruction by diatomizing the stroma. So the bit of heat will reduce the ovarian stroma and that will cause the ovary to ovulate. Do you understand now how it's the logical sort of evolution of wedge resection by Stephen Leventhal, 2 people who did it, and now we have converted it to ovarian. But that can be done with expertise, needs surgical facilities, she has to go under anesthesia, however, and if all the other things are not effective, this is one option, or if she's going for surgery for other reasons like adhesiolysis or something, then this also becomes an option if she has polycystic ovarian syndrome at the same time. Right. Do we give progesterone only pills to induce withdrawal bleed? Possible. Now, one of the progesterone only pills is possible, but they are not. The problem with progesterone only pills is that the period is the period of, if you miss a pill at a certain, the window period is very small. And therefore, there's no point, if you want to withdraw bleed, there's no point in giving progesterone only pills because you have to give it for a longer time. So best thing is to give progesterone or androgenic medication like noethistone. Those are testosterone derivatives for 5 to 10 days, right? And then get a withdrawal bleed. So that is one way which you can run this. Bromocriptine has any function in polycystic? Not really. So bromocriptine has not, has no specific function. We are really talking about hyperprolactinemia, right? And that, of course, has no real connection. Of course, hyperprolactinemia is a part of the workup for infertility, which we need to discuss at a later date. How many cycles can you try giving ovulation? Normally, it is thought 12 cycles, right? And a very, very old study has told us that the risk of ovarian cancer will increase with more than 12 cycles, but it's a very old study. So normally, the other thing is, if you go more than 8-10 cycles, the chance of success is not very great. So if you continue to just induce ovulation induction without moving on to the next phase in your treatment, then of course you will not be achieving anything much, right? So we are looking at maybe 12 cycles maximum, but most centers will restrain themselves to about 6 cycles maximum, and then move on to in vitro fertilization procedures after that. Okay, right. So I think we have answered some questions, or most questions, right? Okay, there's another question. Can clomiphene lead to, or yes, clomiphene can lead to ovarian cyst. It can cause ovarian hyperstimulation syndrome more than letrozole, OHSS. Okay, so it can go to multiple ovarian cysts, and of course it can also give unruptured follicles, and that can grow into a cyst. So it increases cyst formation. Yes. So that is why now usually clomiphene citrate is not recommended over 100. Those days 150, 200 were given, but not anymore, right? Can clomiphene lead to congenital malformation? Not really. Sometimes if you one thing that you have to understand is, if a woman gets pregnant on cyproterone acetate, it is an anti-androgen. It can give under-virilization of a male fetus, right? Because it goes to the baby and it causes, antagonizes the androgen in the baby. And in a male baby, it can give under-virilization. Okay, so cyproterone acetate, if she is given and she becomes pregnant on that, it can cause, or anti-androgens can cause under-virilization of a male fetus. That you have to remember. Okay, so I think we have completed that. So I will choose an obstetric topic. Probably we have to do pregnancy-induced hypertension maybe. Anyway, let me choose a topic for obstetrics next time, and then we'll discuss. Okay? Okay then. Good night.
Good night, sir. Thank you.
Okay, thank you.